Always a pleasure to be with you all. I'll try to keep this brief to allow time for questions. A couple of points to highlight. Our case counts continue to be elevated. In fact, we've had multiple days over 3,000 cases, and we this morning had over 2,600 reported. The state positivity rate is now over 7.6%. The 7-day average case numbers are 44.8 per 100,000, and there are 21 jurisdictions with case rates over 30 cases per 100,000. As we stand locally today, we had 402 cases reported. Our test positivity is now 6%, our average is 6%, and our cases per 100,000 are at 41.5, which is the highest that it's been at any point and continues to increase. Our hospital utilization numbers are holding steady we continue to have the majority of hospitals in the red zone for ICU bed capacity, and we continue to monitor those trends. I would like to say also very clearly, we've started receiving feedback on a number of topics, but there has been a suggestion that we are creating panic intentionally by putting out numbers. We're not doing so. We're simply reporting the numbers where they are, and the numbers speak for themselves. And unfortunately, we continue to see levels that are much higher than we saw in the early stages of the pandemic. And when we look at COVID-related fatalities in November alone, we had 79 fatalities, which was more than the previous 3 months combined. When we talk about to move to testing, we did have in our most recent briefing last week or conversation last week, we talked about some delays experienced by folks at home. And we explained very clearly that this was due to significant capacity secondary to increases in testing demand pre-holidays as well as post-holidays, as we've seen the testing demand still be elevated. A number of the labs, and again, this was across the board, across labs across all jurisdictions across the state and across the country. And some of the labs that we work with have adjusted some of those issues. They brought on additional staff at the request of numerous jurisdictions, including the state, and they have turned around those turnaround times that were significantly delayed back to where they were the pre-spike in demand. Now, as we previously talked about as well, we were not going to just wait for that to be corrected. We do have a number of other labs that we have contracts with that we're working with, and we have an active plan to further diversify the labs that we utilize so that we are not relying on any one particular lab to provide as significant amount of the labs that we had before, which was approximately 85 to 90%. We continue to increase our employee testing platform, which is actually also utilizing a different lab from the one that had the longest wait time. And we will continue to shift those percentages over the next week. We'll continue to update you on doing that. There was also a request to post the wait times related to the labs. Now, we did do some investigating in that and realized that the reports that we get lag a week behind. And so the information putting up this week would reflect last week when we all know that there were significant delays. Again, we have spoken with the labs and we have seen reports, and we can share with you offline that show the improvements in the turnaround time from when they receive the specimen to when they are resulted. The third topic I'd like to just highlight is the ultimate vaccine distribution process. There continue to be a lot of unknowns, but we are continuing to get good information on a regular basis, even on an hourly basis. This morning, in fact, some of the research documents related to the Pfizer vaccine that will be discussed on Thursday. The emergency use application, authorization application will be discussed in their hearing on Thursday, was released this morning. And the data that has been shown as part of those reports suggests that there is significant protection as early as 10 days after the first dose of the vaccine administered, as well as efficacy demonstrated across age, across racial and ethnic category, as well as across gender, with minimal side effects. effects. And this is extremely encouraging, and we will continue to find out more information again as they have their hearing on Thursday. The expectation is if that emergency use authorization is granted, that vaccine will become available within the next week. Now, let me be clear, and again, remind not only you all, but for folks at home, is that there is a predetermined priority grouping that has been done by National Academies of Medicine in terms of what they've put forward to the Commission on Immunization Practices. And the immunization, ACIP is what it's called, has approved the 1A category. And that 1A category says that those folks eligible are in the first wave are healthcare workers and long-term care facilities, inclusive of nursing homes and other assisted living facilities. And as a result, that early distribution, we're expecting there to be approximately 5 to 6 million doses of the Pfizer vaccine administered across the country. And the expectation is that there will be approximately 150,000 doses delivered to the state of Maryland. Those doses will be delivered to hospitals and to pharmacies who will then disseminate and distribute those to the long-term care facilities that I mentioned. There is a second vaccine manufactured by Moderna Pharmaceuticals. Their EUA hearing will be on December 17th. That will also be a 2-dose candidate, and we're still awaiting more information, but the preliminary information suggests that there is 95% effectiveness with the vaccine. Now, we do not know yet the anticipated time of release following their hearing, but the suggestion is that we could have access to that particular candidate, if approved, as early as 4 to 5 days before Christmas. Again, the same dissemination pattern holds with the groupings that have been laid out, 1A, 1B, 2, 3, and 4. And I would encourage folks at home to take a look at the report by the National Academies of Medicine that is being used as the template for those determinations. Now, I want to make another point. We do not make those determinations here on the local level. We started to get letters from folks in the community asking how they can be prioritized and can we make concessions and accommodations for that. Those are not determinations that we make. The state will be providing further guidance as to how those categories will be broken down, particularly as it relates to prioritizing within those priority groups, given the lower amount of supply that we have available, as well as in other categories. For example, determining are there certain categories of healthcare workers that should be prioritized based upon their potential level of exposure. And similarly, when we look at further categories within 1B in particular, and as we move forward in terms of how to break down by health conditions and those and other qualities and characteristics. So we are continuing to get that guidance from the state. I can attest that the state is working on that. Again, I sit on the technical advisory committee that is providing that input for the state, and we met last night to continue those conversations. So I am not withholding any information. I'm sharing with you as much information that has been shared with us so far. And I'll stop there in the interest of time, but as always, happy to answer any questions you all may have. Thank you.
Thank you so much. Dr. Steiner.
Thank you for having us back again. A couple of things I want to comment on. First off, on the enforcement front and education front, we had teams out again this weekend. We did issue one additional citation and we issued one additional warning for businesses that we visited. Both had previously had issues with compliance and were revisits based on those compliance issues, and among others who had to be revisited, 2 did need to have a citation and a warning issued. We had a meeting on Friday morning with our hospitals. A few things to report from that. They're all working to meet the governor's timeline for providing surge capacity, really what they talk about surge capability, because again, as we've talked about before, it's not just a matter of the beds, supplies, machinery, and things like that. It's largely the staffing. All of them are concerned about meeting the staffing limits. And as I shared with council, and I think it's worth sharing publicly, some of them, when they approach companies to do surge staffing for nursing, for example, are getting quotes of $200 an hour or more to try and fill that capacity. And so obviously that's an untenable situation. They are also obviously concerned as well about the state strategy to provide them with volunteers. Staffing an acute care hospital setting with volunteers is something that has not been done, and there are significant concerns about what that means moving forward. In addition, we are dealing with the concerns raised in our nursing homes. There are a significant, we continue to partner with them. There are approximately 48 nursing homes that I believe actually have cases right now. We're working with all of those facilities, Dr. Gale's team, and we are having conversation back and forth about, as we look at additional restrictions, what in the nursing home realm may need to be addressed or nuanced in a way. And so obviously that's a continued area of great focus to ensure that we have safety in those spaces as well. We have significant supplies of PPE. We have shared that with, meaning we've talked to our nursing homes. They have all have ready access to purchasing, but in any place where they're having difficulty, like for example, there's a backlog of gloves right now in certain places in the country and certain vendors. And we have shared the county's vendors with those organizations who need them. And again, if they can't access them for whatever reason, we will not allow them to go without, PPE. And so we will backfill where necessary. So I will stop there.
Terrific. Thank you. Council Vice President Albornoz.
Thank you, Mr. President. Thank you both. There was a report yesterday in the Washington Post and maybe the New York Times as well that talked about that the federal government did not order sufficient supply from Pfizer, and that may impact locally our ability to be able to distribute the amount of vaccines because other countries got in line more quickly than the United States. This is obviously a little above all of our pay grades here, but could you talk a little bit about that, either Dr. Stoddard or Dr. Gales? We know you're part of a larger group of regional partners and stakeholders discussing the vaccine dissemination. Are you concerned about that, and do you feel that might impact us at the local level?
Yes, so the article you referenced highlights the delicate dance we're having to do around this due to the lack or the inappropriateness of the federal response to this. And so part of the challenge is as we continue to build our infrastructure around this, and there are a couple of things I'll add to that and address, is that we don't know the volume. And we're kind of flying a little bit blindly here. And the supply that will be brought in over time. For example, I think there was a report that the United Kingdom is doing mass vaccinations already and starting to do so. We're limited by the capacity that will come from Pfizer. And unfortunately, there will be other vaccine candidates, including Moderna and potentially others through the pipeline as they come on at the early stages of next year. So yes, it will impact us, which is why we're having to sit down and have these discussions about how we create prioritization within prioritization. For example, the hospitals had to submit plans to the state to talk about, even though all of their folks are healthcare workers, how they're breaking it down and prioritizing within those groups, recognizing that the supply will be limited as we roll out. And to help address that in a weird way, it has bought a little bit more time from a staffing perspective and infrastructure perspective. But we are working, as we've talked about before, with our university partners to bring on additional staff, including the nursing students. We also are meeting with at least one outside organization that has stepped up and is looking to help local jurisdictions to be able to provide support in terms of administering the vaccine in the early stages to first line responders in a number of other places. So from a staffing perspective, we've got a diverse set of options that we are utilizing, and we'll continue to pursue those partnerships. But yes, at the end of the day, we are hamstrung by the supply that we will ultimately get from the federal level.
There was no national strategy for testing, contact tracing, PPE, or feeding people. So it was a planning assumption that we had from the beginning that there would not be an effective national strategy for vaccination. And we've been building that into how we've been thinking about it, which is why we've had to do more work on the state and local level to compensate.
Right.
I appreciate that. That's sort of what I thought. Just last two questions very quickly. Obviously the rising numbers are alarming, to say the least, but national trends indicate that a lot of the positive test cases are also skewing younger as compared to the first surge. Are we seeing that here in our community as well?
Yes, so not quite as high as we were seeing over the summer, where we're seeing, upwards of 25 to 30% on a daily basis, but we still see 15 to 20% of new cases in that 0 to 19-year-old age group. And that's an important question because I think there is a misperception in the community that when we say, well, schools aren't super spreaders, but that doesn't mean kids can't spread to others. As we see kids have positive cases in schools, and we've certainly seen the impact of child-to-child transmission in our youth sports and the number of outbreaks that we've seen over time. And so we continue to see kids get it. Now, it may not be to the severity in comparison overall to older age groups, but we do see pediatric cases being hospitalized, and we have seen pediatric-related fatalities.
And last point is just to comment very quickly, Council President, is, we discussed this last week regarding, as you pointed out, Dr. Gales, the issue of school reopenings, the metrics being utilized, it being a moving target. I appreciated the optimism you expressed with both dissemination of a vaccine and then looking at other trends. Again, I want to, because it continues to be the number one, as it should be, and understandably, correspondence we're getting, calls we're getting from a number of family members, understandably exasperated, frustrated, concerned about their children. And then with the numbers that we saw in the disparities in the academic outcomes, it's stark and alarming. So we will be having more discussions in the near future, but just appreciate your ongoing efforts. And I yield back to you, Mr. President.
If I may, Public Health did send along this morning, and Travis, I don't think you'd have a problem with showing the age data that Ann sent this morning, just to illustrate it, if that's okay. I think it's a helpful graph for you all to see. So I think you can probably see this. This is a breakdown by age categories of what we've seen throughout the pandemic. The two dashed lines obviously correspond with our youngest population. And you can see that, we saw this huge spike in the 10 to 19. That sort of has leveled off. It's not going down to where it was in the beginning of the pandemic. And the 0 to 19 has sort of had a slow but steady climb throughout the pandemic. So between the two of them, they represent, I think Dr. Gale said, I think they're about 17% right now as of the last, and that's through the end of November. You can see the oldest adults, the 70s, 80s, account for the fewest percent, and the 20 through 40 range accounts for the highest percent. So you can see where we're at.
Thank you. Councilmember Katz.
Thank you very much, Mr. President. I've had a few questions, obviously we all have, that have been sent in to the office. And one question is, are there currently any travel restrictions from people coming into Maryland, or restrictions that you think might be implemented soon?
So I know the state has followed not quite as closely as some other jurisdictions, but they do have a travel advisory that says, if you're going to places with a certain level of test positivity, I think it's greater than 10%, that's considered to be a high risk area. And there is the recommendation that you quarantine upon arrival and get tested. That's different from, I know there's other states like New York that actually require you to be tested and to provide documentation. And they do track you very closely once you arrive in that jurisdiction.
But at this point,
I think that travel restrictions are most effective when you have areas of high transmission and areas of low transmission. We're already at high transmission, and so you're as likely to be exposed in Montgomery County at this point as you are. So travel restrictions, when they have effect, would be obviously more effective when our case counts are much lower than they are right now. And so I think it's just it's sort of a I think you've passed the point of the efficacy of any sort of travel restrictions. We still encourage people, if they travel, just because when you travel, you tend to go through an airport zone environment where you may be exposed, but it's just as likely you're exposed in Montgomery County as you are anywhere else at this point.
It's an interesting point. Another question is, on the Montgomery County website, it says that that COVID testing sites will test any Montgomery County resident. So what does that mean? Does that mean that we're checking IDs, that if someone is, you're shaking your head already, Earl. So what does it mean?
It's just the principle to say if someone shows up and needs a test, they'll be able to get a test.
So perhaps we might want to reword that a little bit. And you know, I don't know how I know you don't want everybody from Virginia coming over here, but you certainly don't want anyone to believe that if someone is visiting them, that they, from another place, that they couldn't get a test. So anyhow, I don't know.
We discussed this, and it's to your point, Councilmember Katz, that our sites test anyone who shows up, just so we're clear. You know, we obviously want to encourage our residents first and foremost, because obviously if we have floods of people coming in, it just delays the test results for everybody, including our residents. And so we're trying to balance out we want our residents first and foremost, but we do not turn away anyone who comes to our sites.
Okay. And then my final question is about pre-registering for the vaccine with the state or whoever. Are we doing that? Is that happening? And if so, how would it happen if we're going to do that?
So I'm guessing the person is talking about pre-registering for individuals or?
Yeah, individuals.
So at this point, we're not at that stage. So right now, there are two platforms that we are working with the state to utilize to be able to track. There's called Immunet and PrepMod. And PrepMod is a database that allows you to schedule appointments to help facilitate, again, tracking people, the information in the system, so we know who's had what to follow along with the doses. And so that's something that would be available when we reach the stage where we are opening up more to the general public to be able to schedule and come in. But as far as where we stand right now, that's not open because the early stages of distribution of the vaccine will be handled in closed pod mechanisms. And as we move through the phases, and it opens up and becomes more open to different categories, then yes, we would create that opportunity where, scheduling with the system would be utilized.
Okay. Thank you very much thank you both very much for all that you do, and I yield back, Mr. President.
Thank you, Councilmember Rice.
Thank you very much, Mr. President. So, Dr. Gales, I have a couple quick questions for you related, no surprise, to schools. We've heard so much in our community in terms of the slogans of close bars and restaurants, not our schools, close bars and open up our schools. Can we talk about the relationship between the two, first of all? And I know that you, Dr. Stoddard, the health officials from across the state have done painstaking work in terms of drafting a sort of game plan that would mean that schools could go back safely and have laid that out. Unfortunately, it's just that in the community, those benchmarks that you've laid out just haven't been met in the community. It has nothing to do with anyone forcing our schools to stay closed. And I don't want to put this on the Board of Education or the superintendent. Kudos to them for listening to the guidance that they asked for from officials like yourself, but not just you, across the state. Let me just be very clear. This isn't something that is unique to Montgomery County. So if you could just lay a little bit of that out for folks, because there's so much misinformation that's out there, and folks are really trying to listen to slogans rather than science. So.
Sure. Well, I think it's important to acknowledge that, there's parents and students and staff who are advocates on all sides of the issues. Because based upon the emails I've received, there's not just two sides to the issue. There's lots of sides to this particular issue. And we always encourage folks to be advocates, but we want to make sure that folks get the full picture. And as you said, don't slice a quote or a particular, journal article, but, do the due diligence across the board. There are lots of people who are vocal to say open up at the current levels. There's some who are vocal to say open up with some tweaks to it. And then there's a whole lot of also parents who are saying we are still not comfortable opening up where we stand. And so our job, you're right, is to look across all of these different things. When we hear about different studies or we hear about different articles, we do our due diligence to look into those things. And in spite of how it is perceived, I think in some corners, there is not consensus on this issue. We've received a lot recently. We received a lot of information to say, well, why aren't we doing what New York City is doing, what New York State is doing? Well, if you actually look at the metrics that New York State and New York City have laid out, they're more restrictive than what was put forward in the guidance by MCPS and a number of other local jurisdictions. And San Francisco took a similar track, but then you have Los Angeles and Chicago that said, no, we're not opening yet. We're going to postpone and do that later. And so the challenge is to, again, to look across all of the literature to see what the best practices are. And again, not take one study or one example as gospel, but to sit and think very critically and carefully about how we can implement those different strategies and how we move forward. And to your specific question related to bars being open, the fundamental principle of being able to open up schools safely, as evidenced by the comments from Dr. Tony Fauci, if you read his entire quote, he says that, yes, we want kids to be in school. But he also goes on to say that in order to do that safely, you must have lower levels of community transmission. And so there's two parts to the bars and restaurants issue. We know that in order to open schools, we do have to take measures and put in restrictions to drive our community transmission level down to get to the point where we hit those metrics to be able to feel comfortable and confident that schools can open safely. And so I think some people perceive to say, well, you're allowing certain activities to happen. You're not really committed to driving the numbers down. Well, if you also recall, we've received a lot of grief in Montgomery County for being more restrictive than other places by a lot of the same people sometimes. But at the same time, I do understand that because we are committed to identifying those venues that are high risk and do contribute to community transmission. And again, you know very well, you all and folks at home know that we have been very cautious and we are aimed at trying to identify those activities, put in the restrictions. So stay tuned because we want to get the community level transmission down as well to get schools open. So I think that may be what people are talking about in the perception that, certain things are open and why not schools, because we assess each activity in terms of the risk associated with it and its contribution to the number of positive cases that we're seeing.
Dr. Guest, can you just quickly remind me what the state restrictions are on indoor dining versus what Montgomery County's restrictions on indoor dining are?
So the state, I believe, is at 50% capacity. We're at 25% capacity, and we've been.
So we're more restrictive than the state. So we've actually, as it currently sits, so we've done more in terms of saying we're going to be more restrictive for our bars and restaurants than the state has, in terms of trying to control community spread to help to get our kids back to school. I just want to state facts and make sure that things are out there. Because again, there's just so much conversation that's out there about things in terms of where our priorities are. I think it's been very clear. Councilmember Reamer has been very vocal about this. Other members of the council have been very vocal about really trying to get our children back to school, while understanding that we also have to do so safely. We really want to make sure that we're pushing down community spread, which is why we've been so focused on testing, making sure that when it comes to vaccinations. So my last question is about vaccinations. When it comes to vaccinations, there's been a lot of talk now about whether essential employees should include our teachers and school personnel. Do you know of any other jurisdiction in the United States that has taken that step? And is that something that you think we should do in order to try and ensure we balance the mental health and well-being of our children along with the urgency and the reduced amount of vaccinations that we have, the limited supply of vaccinations we have available?
Well, as it currently stands with the priority group distinctions and designations, school teachers are included in the second group, the priority group after 1A and 1B. Excuse me. Now, no jurisdiction at this point has defined that in more detail, because the only group that has been formally approved is Group 1A at this stage. And we're still awaiting those guidelines from ACIP to determine how the rest moves forward. And so again, as to how that will be determined, if there's any changes and tweaks in that, ACIP will provide that guidance, and then each state will also provide that additional guidance to the local jurisdictions. We don't make those determinations at a local level.
Thank you very much, Dr. Gales. Really appreciate that. Now sorry, Dr. Stoddard, didn't mean to cut you off.
That's okay. It's okay. I would only add, and voicing certainly something the county executive has said many times. Our definition of essential workers does not always align with that of the federal government, and so we'll be required to follow certain requirements in terms of what essential employees are and things like that. But where we have deference, we're going to focus more on, front-facing people in grocery stores and other places. Teachers are a great example over those, for example, perhaps in places where they're less exposed, like the financial industry, for example, where they can work remotely and things like that. And so where we have latitude to prioritize at a local level, we'll prioritize those who are more exposed by being front-facing workers in various places.
Thank you.
Thank you very much.
Thank you.
Thank you,
Councilmember
Mr. President.
Who's up?
Sorry, Councilmember Navarro.
Sorry, I didn't hear you. Thank you so much for being here today and for the weekly briefings. So I was wondering if you could restate for our public and for us to take copious notes, if you could restate what you know so far regarding vaccinations, and where would residents be able to access that information? Obviously, this is on everybody's minds. And I appreciate what you have shared so far, but just sort of like for us particularly, and as far as again, if you can restate the sort of timeline, I know it's fluid, but then also where would our residents be able to find this information if they were trying to figure out where we are in this process?
Sure. Well, the two good resources to find that information is the National Academy of Medicine completed the study and report to lay out the priority groups and their rationale for how those are broken down. I'm thinking multiple sites now, so more than two. So that is the first one. The second one would be the Maryland Department of Health website. The state plan, their distribution plan is available for the public to review. And a third site is, if you Google it and you look at, for example, it's called the ACIP, the Commission on Immunization Practices. They will be posting guidelines related to the dissemination of the vaccine and the different groups. And the fourth one is the meeting documents that will be discussed for the Pfizer vaccine on Thursday for their hearing, I think are available on the FDA website. So there are different educational pieces about the process in general, but then the Pfizer information that's specific to that vaccine is available. I can send you all a link, as it was shared with me this morning, but I know that is now open to the general public. In terms of timeline, again, these have to be heard and they have to be approved. So we're speculating. None of these have formally been approved yet, but based upon the early release of information for the Pfizer vaccine, it is the expectation that is likely to be approved on Thursday and thereby could be distributed and be used as early as I think the 14th through the 18th is the time period where that's recommended. And again, those first doses that they're providing are going to go to category 1A, which is to hospitals, healthcare workers, and to long-term care facilities. And as the volume increases, there will be efforts to get all of those people within that group taken care of, and then it will continue to move through the rest of the priority groups. In a best case scenario, meaning that we've got steady supply, which again, even to Councilmember Albornoz's point earlier, there's some issues with the Pfizer supply that we've learned about due to the administration's dealing with that yesterday. But the hope is also with Moderna's vaccine, which will be have a hearing next week. If that comes online as well, there's a second potential source that can be rolled out. In best case scenario, the expectation is we're looking at most likely a 4 to 6 month process as we move through those different priority groups. And again, the general public is in the fourth group. That's the last group, if you will. And the expectation is also that the vaccine will become more available to private providers starting in the second priority group. So realistically, we're looking at a 4 to 6 month process, best case scenario as we move forward. Again, want to emphasize to folks at home is the expectation is the public health guidance around face coverings and physical distancing will not change during that process, because again, we've got to continue to try to get as high a percentage of folks in the public covered and protected with the vaccine as possible. I hope that answers your question.
And it does. Thank you so much. I assume that we will also publish all this information in our portal, right? So that folks can access this information. Is that something that we're planning for? And also partnering with our Por Nuestra Salud y Bienestar, as well as our African American program.
So
Yes. Oh, so sorry. Go ahead.
Just good morning, everyone. I just wanted to weigh in on that, and just to add to that, Councilmember Navarro, that yes, we're at the beginning of phases around communication, and Dr. Gills has talked about all the medical information, the data, and the timing around the testing pieces. We've got a tremendous lift ahead of us between now and the time the vaccine is generally available to the public, to educate them about the truth, to get away from the myths to understand the myths and to respond to the myths, to address those myths, to set some expectations for what that vaccine is going to look like and how it's going to unfold. So in our partners in Salud y Bienestar and in the African American Health Program are going to be key in helping us to craft those messages and get the word out, along with everyone that I'm looking at on this Zoom call right now, because every possible portal we can to educate people is something we need to put out. And one of the plans I know one of the things I know will be is in the works and will happen is updating that information on our portal, on the web portal, so folks have a place to go and get updated, but also proactive and aggressive information dissemination.
Thank you. That's great to hear. The only last thing I will share is that when we had our census update, we were all really, really excited about the results that the effort led by Diane Vu and the Office of Community Partnerships was able to put forth. It was not an easy effort, obviously, because of all the barriers, but it did extraordinary work. And we did say then, we said, well, you guys have put together this extraordinary modeling template. We need to use that for other things. So it occurs to me that we should definitely use them as well to almost deploy that kind of same type of effort that they so aptly did with the census in order to get this vaccine issue taken care of as much as possible, because they were just rock stars in what they were able to accomplish. So I just offer that as well. Thank you.
Thank you, Councilmember Ream.
You're on mute.
Sorry, I was trying to get my window opened. Thank you. Appreciate the presentations today. Very helpful. I'll just continue with where Councilmember Navarro left it. I think I made that comment when we got the presentation as well from Diane Vu. Vaccine reticence is going to be a major problem for us. And it may turn out to be, in a sense, it is, right? Just as big as testing, but potentially just as difficult, like trying to get essential employees to take the vaccinations, but then even beyond that into the communities. I've mentioned this issue previously about the data sharing agreement. I don't know how exactly to talk about that issue. It seems of tremendous concern, but we need an all-out effort to get into, inside people's minds. I don't want to say inside their living rooms because we can't do as much in person, but we got to get that message out. And yeah, if there's an operation, we can just kind of move over from the census count into this. I think that would be tremendously helpful. And as Dr. Gale said, the news that the Pfizer vaccine, and I think it may also, I guess that they don't have the result yet for the Moderna vaccine, but presumably it may be the same. I don't know.
It's comparable. Yeah.
It's comparable. Okay, that it's effective at the first dose. That's going to really improve the timeliness of our ability to make a big difference with the vaccinations. So, we stand ready. I think we'll need, a big program. I know everyone will support the appropriations needed to move as fast as we possibly can on getting out, vaccination campaign. On the challenging topic of, schools and bars and restaurants, I'm coming to think that, or see that I think there's probably more alignment here than maybe it has appeared as far as, state metrics and county metrics and so on. I do want to just observe, I thought it was a helpful framework in the latest guidance from CDC, where they put out that kind of comprehensive guidance. They issued a whole series of mitigation measures that every community should have in order to combat the virus. And then in the footnote they have, or I don't know, narrative, they had this kind of framework saying that, schools should be the last to close and the first to open. As we are heading towards inevitably additional restrictions, and to Dr. Gales' points, California is at stay-at-home orders now, in much of the state. We know we're heading towards additional restrictions. If it is possible for us coming out of that to prioritize the lowest risk school reopenings, which appears to be those younger children, if we can get together with the school employees and the administration and have the testing and tracing and all the programming necessary to make that possible, that would be ideal. The assertion I suppose the comment from the CDC is just that it's lower risk to the community to have younger children in school relative to reopening restaurants for indoor dining and relative to opening stores for indoor retail. Like if you're thinking about it as far as what are the riskiest things to then reopen. Now we know that having those other private businesses shut causes tremendous, consequences for people's lives, and it will increase unemployment. It will create other kinds of difficult actions, and we're going to need to provide funding to support those businesses. I don't think we have a choice, and we'll hope that the federal and state government will help us do that. But, if we could all, work towards and hope that when the numbers come down, and hopefully they will, as a result of additional restrictions, that it is, safe enough to proceed with a limited reopening. We know that only a fraction of students are going to accept, in-person education. Probably the majority will remain virtual through the year. I mean, I think a lot of families just not going to do it. But for that fraction that needs to, that wants to, if we can get to the point where we can make it safe, it would be a big step forward for us. So we're working on it. I think generally, people feel the same about this. So thank you.
Thank you.
Let me just make one comment, if I could. I want to dispel the myth in some in the community, to Councilmember Reamer's point is, we're all committed to working to get there. And we are all committed to looking at new evidence and new data if it suggests that it's safe to do so or safe to tweak where we are. But the process of doing that is, we do our due diligence to make sure we're up to date and we have the relevant information. And again, we don't rely on just one data point. And so if there are information resources that folks come across in terms of studies or in terms of other best practices, then we are happy to, look at them and review them if it means that, we're able to adjust where we stand.
Absolutely.
I was also going to one comment. I was just going to say we also have been looking at activities through the lens of some of the experiences that our non-public schools have had and what has caused some of the cases in their environments. For example, some of the youth sports activities, we have looked at that, thinking about if we do something over here, how will that support or impact our ability to do more or make our education environment safer. And so, as we think about it, we are trying to look through the lens of how do we support education through other actions.
Thanks. Councilmember Friedson.
Thank you, Mr. President. I'll try to be brief. Comments from colleagues on the definite interest to repurpose the effort from the census and the manner in which that was done, the personnel who were able to do it, to be able to work on this issue. Speaking to that, is there a formal county plan, a written out plan for staffing related to the vaccine? And is there a communication strategy that's written out that can be shared with the council of how we're planning to roll this out, how we're planning to deploy staff and resources, and how we're planning to ensure that every Montgomery County resident understands how the vaccine is going to work, where in line they're likely to be, what the timing is going to be, and how they'll be able to access it?
So we, in terms of a written strategy, again, consistent with our previous conversations that we had with you all and what we've discussed today, is a lot of this still is unknown in terms of how to distribute that. Now, we do have infrastructure that we have discussed for months now related to utilizing staff across the county government. So yes, that process has begun in terms of identifying additional staff, their types of support that they could offer based upon their qualifications. That's been done at an HHS level. It's also been done on a county level to assess the capacity of utilizing county staff to be able to support. The second level is, again, as I referenced, there is an outside entity. I'm not going to make it public because we've not had a chance to finalize conversations with them, but a healthcare entity that is partnering with not only us, but they're also partnering with a number of other jurisdictions in the National Capital Region to staff and provide support for those first sets of population groups to get the vaccine. Now, also as it moves forward, we have been bringing on more. For example, here's an example of this. We've been bringing in more contact tracers so that would free up our nursing staff, for example, to be able to participate in vaccine distribution. Now, the governor, as a couple weeks ago in his press conference, talked about being able to utilize school health staff and other staff to be able to bring in to support those mechanisms. And so our plan is looking at how to do that. Again, a large part of the specifics and putting it into writing will be dependent upon what we hear from the state and the federal government in terms of the volume and capacity that we have. And so, yes, there's lots of planning that has gone into it. The writing is fluid at this point because, again, we're waiting to get confirmation that this will move forward and how that will move forward. And as this continues to move forward, we will provide you with updates as we've done so far. And, happy to put it in a written summary as we move forward, but understanding that a lot of these are fluid moving parts and pieces that will be informed, again, by what we find out. Now, as far as the communication strategy, there is a state effort, I think it's called Maryland Go Vax, that they are utilizing, and similar efforts have begun here again on the local jurisdiction. We, the core committee within Public Health Services, came up with a list of different task force, and we can share that PowerPoint with you all as well. And that has been shared with Dr. Crowell around a host of issues. Staffing and workforce is one of them. Communication strategy is another. And that has been discussed at length, at least for the last month and a half, with our comms team around identifying key stakeholders within the community, as Councilmember Navarro mentioned in her comments. As well as recognizing other resources to help be able to do that, because we acknowledge we may not be the best messengers when it comes to that, to be able to address unique individual concerns within communities. So that's a long answer to say that yes, there are strategies in place I believe there is a meeting. I'm looking at Dr. Crowell on my screen. We have a meeting with our comms team tomorrow to talk about rolling out that initial strategy in terms of identifying those key stakeholders. And the last thing I would say is if there's any thoughts from your perspective in terms of suggestions or recommendations or ideas that you have that would add to those efforts, we certainly always are open and appreciate it.
I appreciate it. I know you've done a lot of work on this. I know there's a lot of moving parts. I do think getting it in writing would be helpful for us to provide feedback. I know that there are moving parts and some of it is unclear, but I think that would be really helpful for all of us. Okay. I know all colleagues would be interested in doing that. It would allow us to provide feedback to be able to be supportive. Is there an individual who's in charge of the vaccine effort on the operational and staffing side and also on the communication side? You know, Diane Vu was in charge of census. I think it was helpful for all of us to have an individual point of contact for everybody to know who was in charge. Obviously, there were a whole host of folks in county government who were supporting and helping her at various levels. Do we have that here? Is there a specific person on the vaccine distribution, implementation, staffing, and communication, either one person or one person on each side of that we can turn to?
So we have an immunization team that's part of public health services that's in place with leadership there. So we have the staff there. And I don't think there has been a key person identified for some of those task force. I think, as I referenced, we will be meeting with the communications team tomorrow to identify a key contact, if you will, for that. But we do have an actual immunization team here. Daisy Lucas is our program manager. Comfort Panda is the immediate manager. And then Cindy Edwards is the senior manager for that program.
If you could send that around to us, I think that'd be great. My suggestion would be that one person be in charge of coordinating the communications and the operations and staffing, even if they're not a subject matter expert in the immunization, immunology side of things, just so there's one person who kind of understands both sides of the store. Last thing here. You can feel free to contact us as well. I mean, we've got our finger on the pulse of all of it.
Yeah, and I would just illustrate just the complexity of this. I know I listened into the previous conversation about the county's financial outlook and the challenges that we face there. But over the next coming months, it's going to be very hard to distinguish what's COVID response and what's the rest of county government, because we're having a conversation tomorrow with DCAO Kasiri around what activities that county government is currently doing can we stop doing to provide staffing support to vaccination, to 311, to the HHS call center, to enforcement, to all these things that we know that we need to do more of. And so it's going to become increasingly challenged to distinguish what is county government from what is COVID response. I think it's just,
I'm thrilled that that's happening. I've been told by some department directors that that's finally happening. I think it's about 9 months late, but I'm glad that it is finally happening to redeploy to where the immediate crisis is. Just last piece, I appreciate the fact that we're diversifying test labs. I think that's really important. We shouldn't be relying 80 or 90% of the county's testing on one particular entity. If there are delays, if there are issues, that diversity is important. But on the posting of times, I appreciate, Dr. Gales, what you were saying, how it's a week delayed. I still think it's important for it to be posted. I just think you should make sure that it is noted that if these are 1 week delayed times and don't reflect the current realities, I think that level of transparency and accountability would be helpful. I think it would be appreciated by residents. And so I would still hope that we will proceed and move forward with that. Thank you, Mr. President.
Right. Thank you. Councilmember Glass.
Thank you, Mr. President. So I went to the dashboard during this conversation and saw that 75% of our hospital beds are occupied, and 20% of those beds are occupied with individuals with COVID. And those facts are alarming. And we now have the highest transmission rates, as Dr. Gales opened this conversation stating. And so as it relates to our communication strategy and as it relates to the information that's being shared, this information is not hyperbolic. They are facts. And the fact is that our hospitals are nearing capacity. And that's why we are taking the actions that we are, so that those individuals, our residents who do get sick and need medical care, have it. It's as simple as that. And so the the graphics and all of the other information that the county is sharing, it's unvarnished truth. And if people are alarmed by it, that's the reality, which is why we all need to take the precautions that we've all been espousing. And so, I just wanted to share that and express my support for that strategy and express the support for everything that we in county government have been trying to do over the last 9 months. And it's only going to get worse, with national medical experts saying that the health crisis that we'll be facing this winter will be the worst health crisis in American history. And so that information that we have from our county and from our healthcare facilities needs to continue to be shared. And I appreciate all that Dr. Gales and Dr. Stoddard are continuing to do. And in the words of the late John McCain, it's straight talk, and we need to continue engaging in that type of conversation with our constituents. Thank you very much. I yield back.